Welcome along everyone to our Q&A session. I'm Christie with the PBC Foundation. We've got Professor Jones joining us today. Thank you so much for taking the time again. We really appreciate it.
From near Washington. Unfortunately, it's Washington in County Durham.
A little bit of housekeeping. Remember that these sessions don't take the place of a consultation with your own clinician. We're aiming here to provide some general medical information and not specific medical advice. And we'll generalise your questions in support of that. So just if you've got a more detailed issue, please contact us on the helpline. So I've put a little bit about the chat as well. I'm going to be recording the session here in ClickMeeting, which I'll upload to our YouTube channel as well. But just a reminder that the only parts that are recorded are the 2 video links with Professor Jones and myself. The content in the chat box is not recorded, so that's a safe space. Professor Jones, before we start today, I thought it might be good. I've got a few questions for you that we've had sent in, but I thought it might be good just to cover. I'd emailed you last week about this. It was Liver Cancer Awareness Month last month, and we put some information up on our socials about it, and it did generate a wee bit of chat. So when I came to you, what I'd said was, so my general question was, is there any indication that it's becoming more prevalent, or is it still a small subsection of PBC patients who have developed cirrhosis who may then go on to develop liver cancer? And you gave me quite a detailed response, and I thought it would be really quite nice if we could do that in a video here this morning as well, and then I would be able to do a short on it.
You know me, I can't do anything in a short period of time. Just before we do that, actually, some interesting and positive news is that for watchers of this, it feels like at 2 o'clock on a Thursday, we spend our life talking about drug regulation and drug approvals and things like that. And to cut a long story short, people who are familiar with the issues about obeticholic acid and approval and withdrawal and the other drugs. And part of the issue is the impossibility of doing a clinical trial where people are taking a dummy tablet, where the outcome measure for the trial in simple terms is their death, when that treatment is available. It is not ethical or practical or sensible to expect people to do that. And the big argument we've been having is to use different ways of showing effects, okay? So to actually use different information and to say sometimes we can't do a trial like that. We just can't. So what is an alternative? And here this whole question of real world evidence that a number of us have worked on for a number of years is that actually very large amounts of information that PBC patients are always very happy to give as part of what they do. And part of the frustration for all of us was in America and in Europe, in the EU, they not listening, we're not going to do all of that. The MHRA, and we knew this was coming, the MHRA, which regulates drugs in the UK, so for all the UK viewers, that's what matters, issued a paper at the weekend saying they're going to use real world evidence, okay? Now that sounds like, and I suspect you and Robert probably don't know that, so please pass it on. Now the devil will be in the detail. I'll forward on that document for anybody who's interested. I mean, I'll send it on to Mo. It's really important. They've listened to the patients groups and to the experts and industry and everything like that. And it all depends on what they do in practice, but they go, yeah, there is a way you can use this evidence. And so potentially this is a way through in the UK, the obeticholic acid challenge. And so we've been trying to, we all accept you have to understand whether drugs are safe and effective. Nobody's arguing that you don't. You have to do that, but you also have to be able to do it in order to answer it. So that's just a little bit of positive news.
Brilliant.
We'll see how that goes. Right, liver cancer. So liver cancers, there are 2 sorts of liver cancer, basically. There are what are called primary liver cancers. That's a cancer that develops in a liver cell. And there are secondary liver cancers, which is where there's been spread to the liver. And actually in the population, by far and away, the commonest type of liver cancer is actually secondary liver cancer, usually from bowel or something like that. So we're talking about primary liver cancers. There are, again, 2 of those. One is hepatocellular carcinoma, often abbreviated to hepatoma or HCC. You'll see those terms used. And then the other one is a thing called cholangiocarcinoma, and that's a cancer of the bile ducts, which is a complication in PSC, but not PBC ever, okay? And it is, although there are aspects of PSC and PBC, primary sclerosing cholangitis and primary biliary cholangitis, that look similar, there are some profound differences, and the cancer risk is one of them. So cholangiocarcinoma, we won't talk about secondary cancers, we won't talk about cholangiocarcinomas. Neither of those are more or less common in PBC. So hepatocellular carcinoma. So these are can arise usually, almost always, in people with chronic liver disease. So it is incredibly rare. Most people who get, say, a colon cancer haven't got colitis. Okay, so there is an increased risk if you've got colitis a little bit, but most people who've got colitis, most people who get cancer don't have those things. It's a spontaneous thing. Hepatocellular carcinoma, it almost never is, certainly in our population. Far East, bit different, but where viruses are, the viral pattern's different. But in the UK, North America, vanishingly uncommon for it to be in anybody other than somebody with chronic liver disease because of the inflammation, irritation of the liver. And because part of liver disease is the liver regenerates when it's damaged, that's how cancers can arise. And that, of course, only happens in cirrhosis. So it is a feature of chronic liver disease, especially uniquely cirrhosis. Okay, so anybody here who's got early stage PBC, who's got no fibrosis, you can forget the risk, okay? It doesn't exist. There's also some interesting evidence that we never see liver cancers in people who respond to URSO or respond to second-line therapy. Another reason to get better control of the disease. There are lots of reasons, but cancer is one of them. So some nice data from the Birmingham people about that. So it occurs in people with cirrhosis and poorly controlled disease. Now, liver cancer in every disease is commoner in men than in women, and that's because of testosterone. Okay, so testosterone is a growth factor for liver cancers. So men with cirrhotic PBC are the only group who we ever really see this with any frequency, and even then it's rare. And in women, it's incredibly uncommon. And so I've not seen a liver cancer. I can't speak for Jess, my colleague. She might have seen, but I haven't seen a liver cancer in one of my patients for years and years and years. And we do follow it. Now, people worry about it. We screen for it. So anybody who's cirrhotic, we do ultrasound scans every 6 months. The kind of good news is that there are really effective treatments for it nowadays. A thing called radiofrequency ablation, which is essentially microwave on a stick. Not to make it unscientific, but you put a probe into the tumor and you switch the button and it microwaves it from the end of the probe. And so it just kills the cancer. It's really effective, done as a day case, right? So so it is really important to look for it. It's very important because you can manage it really effectively from the very beginning, but it's actually very, very uncommon. The only group to watch out for, be aware of it in anybody with cirrhosis. And be particularly aware in men with cirrhosis. So what can you do? Not be cirrhotic, which is have really good control of your disease. If you are cirrhotic, have really good control of your disease. And if you are cirrhotic and your doctor suggests having a 6-monthly ultrasound scan, do that. You're not trying to make a diagnosis that then kind of is just terrible news. You're trying to make, it's like finding a polyp in a colon. The early treatment is really simple. And it makes a big difference. So it really, of all the liver diseases as a whole, PBC is by far and away the least likely one to see primary liver cancers. It is mainly a feature of viral hepatitis and of obesity-related liver disease. So it is a cirrhotic feature, but not all cirrhosis is the same. And it goes back to the fact that these other ones are true liver diseases, whereas in PBC, the liver injury is a kind of consequence of the bile duct change. Although, ironically, you don't get bile duct cancers in PBC. So it is a thing to be aware of, but it's not a thing to be worried about. I'll just give a general comment about cancer. Everyone worries about cancer. PBC is uniquely not associated with any cancer, really. So we looked at this years and years ago. There used to be an urban myth out. There was a paper out there published which described a whole series of women with PBC who developed breast cancer. And it's still out there on the internet, and it caused a lot of worry, and it still appears every so often. And basically, it was here are 10 women who had PBC and breast cancers. Gosh, there must be a link between PBC and breast cancer. When you did a case control study, which is you looked at women with PBC versus women without PBC, what you found is exactly the same number of breast cancer. In fact, a little bit less in PBC. And what does that tell you? It tells you that PBC is that, unfortunately, sadly, breast cancer is common, and it is common in women with PBC, and it's common in women without PBC, and PBC makes no difference to it at all. And it creates a lot of anxiety for people. But if I pointed out the and overall, it seemed quite high because it's mainly a disease in women. But if we'd written a paper, it wasn't us that wrote it, if somebody had written a paper saying PBC protects you against having prostate cancer, you would say, well, that's crazy because there aren't very many men. But it's no more illogical than the breast cancer thing. So there is no additional risk of cancer of any sort other than this small increase in hepatocellular cancer in PBC. But having PBC does not protect you against any cancer. So just make sure you do have all the screening and the things that are recommended as normal. One thing that is really important is we sometimes come across that urban myth is going to be the kind of theme of the day, isn't it? So one of the things we come across is this idea that you can't have operations when you've got PBC and you can't take certain drugs. So I have encountered people who've had cancer unrelated to their PBC where they've been told they can't have the right operation or the right chemotherapy because of their PBC. That is nonsense. Absolute nonsense. And one of the reasons we don't discharge anybody out from the clinic is that we keep the files open, and that means that people will think to contact us if people are going to have those things. So, there are certain tricks and things you need to be aware of if people have got cirrhosis usually, but to a 99% level of certainty, there is no intervention that you might need for another condition that you can't have because you've got PBC, and ignorance can be quite dangerous in that setting. And so it's difficult for us to issue guidance on every cancer and every operation, but it's not an issue. And if people worry about liver blood tests, well, that's what we're here to do. That's what we do. So we just say to people, let us know when you're doing it. We'll watch and comment.
Great, thank you. A question now about an alternative treatment. So we know that although we have some chat about that in here, that nobody should start anything without speaking to their own consultant, but we've got someone who's interested to know if there is any positive negatives research into the use of lion's mane. There seems to be all the rage at the moment, offered in drinks, and a whole variety of health benefits, including with brain function and also the liver.
No is the short answer. Not aware that anybody's thought about it or looked at it. And like all of these things, I think good research comes from good ideas, I mean, research comes from good ideas, and good ideas come from people spotting things, okay? And people think that, enormous brain scientists sit in laboratories and come up with hypotheses, but actually most really good research, most therapies actually come from people making an observation. And I've told people many times that that the first observation of fatigue and brain fog in PBC came from a medical student who worked with us called Jenny Goldblatt. And she was really bored as a student, and she said, can I come and see some patients? So I said, yeah. And she came and sat in my clinic. At the end of the clinic, she said, they're all tired, And I said, no, they're not. And she said, shows what I know. And no, they're not. She said, yeah, they are. They all say the same thing. All the patients said exactly the same thing. I thought it was really interesting. Then next week we talked about it, and the whole of the science of fatigue and PBC came from a smart girl sitting in the clinic, actually listening to people rather than channel thinking. So those things. So I think like all of these things, this is one of the advantages of the dialogue that we all have as a community is we file these things away. And I think if people were to come back into these things with experience of these interventions being helpful, and then it becomes something that it's worth capturing information on. So I put that one out there to you as the community, is you tell us whether there is a clear sense of benefit. There won't be any harm from it, okay? And ultimately, is there any benefit? I don't know, but it will be worth looking at. Interestingly, just as an aside, I mean, because unfortunately, I'm here working really hard while Mo has a lovely time in Washington. do have a nice time. Don't think of me at all, stuck here working. Did I mention I was working?
I'm at that point though, I don't know what day it is yet. I'm still, it's back at 9 here in the morning now, and I'm a bit like, we just arrived like last night and I'm not quite sure what day it is or where I am, but.
What I do think is really interesting, there's going to be some really, I mean, there's always interesting data at ASLD, but there's some particularly interesting stuff around elafibranor, which is Mark Swain, who's obviously a friend of us and of the foundation, and is one of the people who, along with us, really interested in fatigue. So they've been doing some work around mitochondria. So mitochondria are the kind of batteries of the cell. They turn food and take food and turn it into energy, basically. And of course, and if you have an abnormality in your mitochondria, you can have kind of genetic problems with them. Then people get fatigue, and they get a lot of the problems similar to the ones that PBC patients get. Now, we've always been very interested in that. And of course, AMA is anti-mitochondrial antibodies. So antibodies in PBC are antibodies against mitochondria. So you kind of sit and think about all of this, and you think, there's something interesting there, isn't there? But it's always been quite difficult to prove a connection with it. But we did some work looking at PBC. Blood from PBC patients can make cells switch off their mitochondria. So there's something interesting about that. And then Mark Swain has some data at SLD showing that PBC patients have changes in proteins that are important for mitochondrial function, and that those are associated with fatigue. So those, and this was shown before, but those abnormalities are linked to the severity of fatigue. So the more fatigued you are, the more likely you are to have these abnormalities. What they showed also is that we've known for a while that elafibranor seems, and I take this as a caveat, seems to have a beneficial effect for fatigue. Time will tell. And, we need to be aware of placebo effects and all of those things. But, in our experience, that would seem to be the case. It needs further work. We're talking to the company about doing proper studies of it all. But he's shown now that that improvement in fatigue is associated with an improvement in mitochondrial function. So we wonder if elafibranor does this. Interestingly, seladelpar doesn't appear to. Obeticholic acid does appear to in certain situations. And of course, we think of seladelpar and elafibranor as the PPAR agonists, as being two sides of the same coin, except they're not actually, because they have slightly different functions. And there is a pattern of action of elafibranor that has something that seladelpar doesn't have, and the theory might be that that's beneficial. So watch this space. I don't want anybody to run away and think it's the answer to fatigue, but I think it's interesting and it's intriguing. The moment you've got a mechanism change, it becomes interesting. What I would say about lion's mane and things like that is a lot of these things turn out to be antioxidants. So oxidant stress, free radicals, inflammation is very important in disease, important in fatigue. And a lot of the treatments we use actually have a root in antioxidant action. Urso does, for example. So it may be an element of that. Is there anything sort of beyond that? And we don't know, but I'd be interested for people to say.
Great, thank you. And I will also go and seek out that information from Mark Swain while I'm here at ASLD, and we can bring that back to
I think so. And obviously nobody in the world ever felt better because their mitochondrial protein profile changed. But if you've got a change in the symptom, people feel better. It could be because Mark Swain's a nice person and make people feel better. He's a nice person, makes people feel better. And that's fine. If you feel better, you feel better. The problem is that then doesn't apply to somebody miserable like me giving blood to somebody, so the thing about placebo effects, particularly symptoms, it's not about you. If you feel better, you're better, right? It's about whether you could reasonably expect somebody else to do that. And if you have a symptom benefit, but also a mechanism change, it implies it's real, okay? And that's why it's important that the changes themselves, in a way, don't change whether you feel better or not. You either feel better or you don't. But it does suggest that it might be something that is overt about it all, which is interesting.
Great. Thank you. We've got you touched on earlier there, actually saying that there's sometimes when you have PBC and not sure what else you can take. So what painkillers for pain relief when paracetamol isn't strong enough? So the examples given's been a migraine, and I think the doctor's just about not sure what to prescribe for this patient.
Yeah, okay. I laugh because it's the day of urban myths, isn't it? It's Urban Myth Day. So let's have a list of them. Actually, maybe that's a bare facts thing someday, is urban myths, our favourite urban myths.
Actually, that well remembered, bare facts. The article's due soon, so I'll be popping you an email about timescales for that. Yes.
I walked into that.
You did? Because if you had mentioned bare facts, I would have forgot.
I walked into it. Urban myths. Okay, so another urban myth is you can't take Brufen or non-steroidal anti-inflammatory drugs with PBC, okay? And I'm told this repeatedly by people who've been told by their GPs, and I have no idea where that comes from, and it is complete nonsense, okay? Now, non-steroidal anti-inflammatory drug. So paracetamol is a straight painkiller, okay? So what it does is damp down the inflammation, where the injury is, so you get less of a signal. Ibuprofen and non-steroidal anti-inflammatory drugs are also anti-inflammatory. They damp it down a slightly different way, and so those two are complementary to each other. Paracetamol reduces temperatures as well. Brufen doesn't tend to do that, and so that's why a combination of paracetamol and ibuprofen is actually quite a good combination, because they work in additive ways. The issue with ibuprofen and non-steroidal anti-inflammatory drugs is that they can cause stomach upset disturbance that many people are familiar with. Now, that is something, if you tend to get that, you can mitigate it with anti-acid treatments, but it's not usually a big deal. So both of those are fine. People think, God, liver disease, paracetamol, I can't possibly take it. Remember, paracetamol is only harmful in liver disease if you take it in overdose. Now, watch out for 90% of overdoses of paracetamol are in people who tried to harm themselves, okay? But 10% are inadvertent. And they are where people take some paracetamol, but they also take some night nurse or something like that. They don't read the label. So now has paracetamol written. And that was because people were, in all good faith, not realizing they were taking, extra paracetamol. So do really be careful about that. You don't need to. Paracetamol is fine. I tend to say to anybody with liver disease, drop your paracetamol dose by about half. So, 2-4 times a day. If you haven't got liver disease, drop it to 1-4 times a day with liver disease, and you won't go wrong. It's still the safest. Even if you're in hospital with liver failure, paracetamol is still the safest painkiller, actually. But you just have to adjust the dose. Brufen is fine. If you've got stomach problems, then take you can get proton pump inhibitors, get omeprazole over the counter these days, pantoprazole over the counter, get it from your doctor. So those combinations together. What I would say is that both of those work far better if you take them in advance. So I gather from somebody who had a knee replacement last year, can't remember who that is, but that actually you're better to take, I found, whoever this was, found that taking Brufen every day in advance, just 1 or 2 tablets in the morning, was fine for the whole day. And so rather than waiting to have discomfort, I took just a fixed small dose. I didn't take 3 times a day like you can do. I just took it in the morning, got going, and it was all fine. So a low dose of Brufen given regularly is better than a higher dose given in response to discomfort. So those are sensible. After that, you can have more and more powerful non-steroidals, okay? So naproxen, indomethacin, things like that. And the more powerful they are in terms of anti-inflammatory, the more stomach toxic they are. So you need to remember that. So most people with Brufen are fine. Once you get into the other ones, you're more likely to get stomach problems, but they're more likely to be effective. So just be aware of that. Then you get into other types of painkiller. Most of those are actually opiates of some form or another. So you get codeine, okay? So you can buy codeine tablets, and the commonest way of taking that is actually as a thing called cocodamol, or codeine and paracetamol as a combination treatment. The thing about opiates is they don't take the pain away, but they make it less unpleasant, okay? So they alter the nature of the sensation. And that can feel a bit funny, if you like. So I have to be honest. I mean, there'll be several people, who've had big operations and things. After I had my knee done, I hated, opiates actually, because they made me feel rotten, and they didn't take the pain away. They just made me feel like a zombie. So actually, I didn't take any. I just took Brufen and paracetamol. I had cocodamol, and it just kind of was funny. So they're different in different people. I would, generally speaking, try and avoid opiates with PBC. Why? Because you don't clear them very well, and they can make you feel dopey, which will make brain fog worse, and they make itch worse. We use naltrexone to control itch, which is an opiate which blocks your natural opiates. So I would try and avoid opiates if you can. For something like migraine specifically, there are specific therapies for it. So beta blockers, sumatriptan, there are particular categories of painkillers. So go and chat to your doctor about that. That's a different sort of pain because it's a blood vessel constriction pain. You can treat that in a different way. I recommend a lot of use of TENS machines, transcutaneous nerve stimulation. It's a bit like, it's a scientific version of rubbing it better if it's painful. So you get an alternative sensation which fools your brain. I get a bit of back pain. I've got a TENS machine. It works like a treat. Okay, it really works a treat. And one of we're in a world where some things in life are difficult nowadays and some things are easy, but these used to get these on prescription. You now get them for 20 quid from Superdrug or Boots or whatever. So they're really good. Okay, it's really good. Use it all
I have
the time.
one as well. Yeah.
Just get yourself a TENS machine.
Yeah.
If I've got a bad back, I just use it rather than painkillers, and it works really well. Over and above that, we use quite a lot of gabapentin. Again, I'm told all the time that people become addicted to it and have enormous problems. I've literally never seen that. We use gabapentin very effectively. We use it for pain control, particularly nerve root pain. You've got a nerve disc that gives you trapped nerve. Also, it's very good for itch in PBC. And again, lots of urban myths about addiction with it. As a rule, I was always taught when I was a young doctor back in the sort of early 19th century that you don't get addicted to opiates and things if you still have pain. That as long as you reduce the pain to the point at which it was still there but not gone completely, then you wouldn't get addiction. I think that's right. I think your body, all you're doing is upping the natural protective things. So generally, keep it simple, paracetamol and brufen, given in advance rather than anything else. And remember, things like back pain, a lot of joint pain are spasm in the muscles, not actual arthritis. And so actually keeping mobile is really good. So keeping mobile. So when my back, that's all about me, isn't it? When my back is really bad, I always feel the muscles, scrunching down. And of course, that's why TENS works, because it relaxes the muscles. So don't think it's automatically arthritis or something. It's often just the muscles spasming as a result. And if you get mobilized and get around that, then often that's better. And other than that, so but with migraine, there are specific therapies which are probably worth looking at. What I do know about migraine, I don't know very much about it, is that of course once you have a migraine attack, your stomach stops working. And so if you are going to get a migraine attack, you need to give your painkillers immediately when you think it's about to happen, because when it actually happens, it's too late, because it will sit in your stomach. And some of these medicines are given as injections underneath the skin. You give yourself an injection. We used to be in a world when nobody would ever give themselves an injection. They thought the horror of that, apart from people with diabetes, where it was normal, but nobody countenanced it until Wegovy came along, and Mounjaro, and now everybody does it. So it's made life easier. Again, without it being all about me, when I needed to be on blood thinners after my operation, I chose to stay on warfarin, on tinzaparin, injected heparin, rather than taking warfarin, which is rat poison, because it's just easier. And so, so don't be frightened of injections that you give yourself under the skin. But for migraine, those are really effective because they bypass this kind of stomach sitting there and not working thing.
Right. This is a different question, an unusual question. Does being diagnosed with seronegative PBC, I had positive ANA negative AMA, mean that the disease will eventually progress differently or faster? Diagnosed 15 months ago and considered an URSO responder, and luckily I'm experiencing little or no symptoms, and at last scan biopsy in the summer, there was no fibrosis detected so far, and my last blood test results were all within normal limits. Yeah. I'm still concerned that the disease may eventually progress faster, or I may experience additional challenges because of being seronegative. Yeah,
it's a really good question. So there are two types of antibodies that are characteristic in PBC. The 95% of people get AMA, anti-mitochondrial antibody we talked about, but 5% don't. And those other 5%, the majority have an anti-nuclear antibody, which as its name suggests is an antibody against the nucleus. Okay. Yeah. there is a very, very small group of people who have neither. And of course, you only diagnose those on a liver biopsy because you can't diagnose it otherwise. Having had a liver biopsy to diagnose PBC, is that sensible? Yes, it is in this situation, because once you don't have AMA and you do have anti-nuclear antibody, it's a little bit more complicated. And so remember what I say all the time is that the majority of people with PBC don't need a biopsy, but a small group do. And don't be frightened of it in those situations, because it will set you off on the right track. So why is ANA more complicated than AMA? Well, the answer is that it's associated with more conditions. So whereas AMA is uniquely PBC, so the only liver disease that gets it is PBC, and PBC patients almost always have it. Anti-nuclear antibody you can see in other types of diseases. In particular, one of the other autoimmune conditions called autoimmune hepatitis. Okay, now, and where it gets really complicated is people with PBC can also have, so you can have PBC on its own, you can have autoimmune hepatitis on its own, or you can have a combination of both. And that's why they'll have done the biopsy, because trying to understand that is very important, because the treatments are different. If you've got PBC, you need PBC treatment. You've got autoimmune hepatitis, you need hepatitis treatment. If you've got both, you need both, right? It's simple. Now, you can tell whether it's an autoimmune hepatitis antibody or a PBC antibody by the pattern of the anti-nuclear antibody. Okay, what do I mean by that? Well, when you detect these by basically in the lab, they spin some cells onto a slide. Okay, some cells there, and then they add your serum, and then they let that dry off, and then they add another antibody with a coloured marker to that, and they see where your antibody has stuck. Right. And obviously for AMA, it's the mitochondria in the cell, and for ANA, it's the nucleus. Okay, and that's how they do it. So it's how it was originally detected in the 1950s. It's still what they do. The pattern of the pattern of mitochondrial staining is always the same. Okay, so AMA always gives you the same pattern. It never differs from person to person. But ANA has different patterns in different people. So the patterns for autoimmune hepatitis and PBC are completely different. So a good laboratory can tell you which of them it is. It's completely different. One is diffuse throughout the nucleus, and one is patchy, usually a rim around the nucleus, or dots throughout the nucleus. Right. So once somebody who you think has got PBC because of the liver blood test, once you think that's the case and they've got anti-nuclear antibody, the first question has to be, what is the pattern? Okay, what is the pattern? And if it is a patchy around the rim or dots, then that's the equivalent of AMA in terms of PBC. So it gives you exactly the same diagnosis and everything. If it's diffuse, then it's a PBC, it's an AIH type antibody. Now, that doesn't mean you've got AIH, it means you've got an AIH type antibody. And that's where you'd really want to know what the other blood tests look like to see whether you felt there was an element of autoimmune hepatitis, and or do a liver biopsy as they've done. So there are ways that you can detect it. We spend a lot of time kind of micro dissecting all of this, because it does make a difference in terms of the treatments that you use. It doesn't make it more difficult to treat, it just means you need a different approach. So you need to get it right. If you're an URSO responder, then it's likely it was a PBC autoantibody, and it's a PBC one, in which case it makes no difference. In terms of risk, okay, basically two things determine your risk. One is what your blood tests are like after you have been established on treatment, okay? And then the other is, what is your FibroScan at the beginning, and how does that change over time? And so essentially you've got, if you think of it as 4 quadrants, 2x2 table, you've got good bloods and bad bloods, you've got good FibroScan and bad FibroScan, and we want you to be in the good bloods, good FibroScan category, okay? And so actually, various people will come up with theories about this antibody and that antibody, but in truth, none of those matter. It is only about what are your blood tests after you've been treated, and what was your starting point for the FibroScan. This is why FibroScan is so important for routine follow-up, because it sets the context in terms of what we do. There are people who say, and this might be underneath what you're sort of asking, is that these anti-nuclear antibodies are associated with higher risk PBC. I'm not sure I believe that. I think that's a nice story, and it does not enter into our decision making about treatment at all. We treat on the basis of what's actually happening, not a theoretical risk of what could happen. So just double check with your clinician, go and ask them what was the pattern of your anti-nuclear antibody, and they'll mumble and check on the screen, and then they'll tell you because the lab will report it. And then you're looking for it being a sort of patchy or a nuclear sort of rim or a multiple dot, in which case that's classic PBC. If it's more diffuse, it needs a little bit more thinking about whether it's autohepatitis or not, but they've done a biopsy, which is the right thing to do. But it is important to get that right. But at the end of the day, with all treatments for all liver diseases, frankly, it's what happens with treatment is confirms your diagnosis, doesn't it? So it sounds, what it's worth, it sounds like they've done a very good job of working that up. So you should have real confidence.
Okay. Couple of PBC.
Sorry.
Yeah.
I lured Mo into being able to ask another question. The one thing I wouldn't keep doing is repeat the autoantibodies, actually, because changing them doesn't really make any difference. So once you've kind of got the diagnosis, it doesn't change. If it goes up, it doesn't matter. If it goes down, it doesn't matter. If it disappears, it doesn't really matter. You've still got PBC. And so I wouldn't worry about repeat values for that. You've kind of, once you've passed the test, you've passed the test.
Okay. A couple of PBC and questions. Is it true if you have PBC, you're more likely to get AFib?
Sorry, if you've got PBC, you're more likely to get
AFib.
atrial fibrillation? No.
No. Right. Is there any connection between PBC and lung issues?
Gosh, now, a little bit, okay? A little bit. So some PBC patients get a bit of scarring in their lungs, okay? So they can get a little bit of lung fibrosis. It's not a common problem, and it's kind of there if you look at it. And that's probably part of the disease process. And then the other thing that we do see occasionally, and when I say occasionally, a little bit more than you would expect in the population, although it's still very rare, is a thing called pulmonary hypertension. So where the blood pressure on the lung side of the circulation, as opposed to the peripheral artery circulation, is high. And that can give you some shortness of breath. But I have to say, those are not common at all. And they're in the kind of once a year category for us. You'll maybe see them once a year, but you would see them because you look for them because you're aware that they're there. So it's like all of these things, is that because we're aware of these things, we're obsessional completists, and don't worry about these things. So there's a small association. I mean, conceivably, pulmonary hypertension can be associated with atrial fibrillation. So if you really, really wanted to stretch it, it is. But it's what would I expect to see over the next month in my clinic is always a reasonable test I use for these sorts of conversations. And what is the likelihood of me seeing anybody with a lung problem over the next month? Zero. I mean, I might see one a year, hepatocellular carcinoma one every 5 years, and that's in a dedicated PBC clinic. So these are not common at all. PBC is a funny condition. It has almost no surprises. Is that, it has its dry eyes and dry mouth and its symptoms and the things that it does, and maybe a little bit of absorptive things, but they're all part of the disease. In terms of major disease associations, it simply really doesn't have any. Which makes the PBC and relatively boring, actually.
Okay, couple of questions about Urso. Recently diagnosed with PBC, female, 71 years of age. Consultant has prescribed a dose of 750 milligrams of Urso daily. I'm over 10 stone 7 and 4'11" in height. Looking at your chart for weight and dosage, it looks like I should have had a higher dose than this. Yeah. Is it possibly due to my age or some other factors?
Because I was going to say, you're stuck in Washington. I'm here working, by the way, but you're in Washington, which is very nice. Presumably nice this time of year. But I'm not there, so I don't know. You don't have the Urso adjustment chart. Did you not bring one with you?
They're in my kit, ready to put out on booth. Yeah. I don't have it to hand like I usually do in my own office.
Yeah, so it is important to get the dose right. It's not mega important, if you know what I mean. And actually, if people are responding very well to whatever dose they're on, then actually it's the right dose for them. But generally speaking, get it right when you start and stick at that dose and don't fiddle with it. Age wouldn't come into the dosing at all. It's not cleared by your kidneys or anything. Sorts of things you might need to be cautious about with age. And so it probably sounds like it's a little bit low. So it sounds like a gram for me. Why do doctors do it? there's a legacy thing. When I was a lad, everyone got 600 milligrams a day, which is basically, an underdose for everybody. That was when it's first introduced. And we've still got people who take 600 milligrams a day. Why haven't we increased it? Well, because they've got normal liver blood tests. And what are you treating? How would you know if it was successful increasing it if they've responded fully? So the answer is urso. You need to take enough urso to get the control that you want, i.e. to have normal liver blood tests, but don't take above 15 milligrams per kilogram. But if you're taking below 13, it's not the end of the world. But if you're not a responder enough, for what you want, the first thing you should do is increase the dose a bit. So it sounds like it's a bit light for me, and they shouldn't be adjusting it for dose, for age, or anything else. And it may be that your clinician is perhaps a little bit behind the times.
Okay. I'm going to say something that I don't think I've ever said before in a session with us, is that I'm about
It's very kind of you to say that about my expertise and genius and gentle sense of humour, but I will take the compliment, thank you.
I am about to ask the last question on my list. I never get to the last question on my list. So to people in the room, we are going to have some time today. So please make sure if you have any questions for us, get them in the chat, because I'm on to the last one that I've been sent in, and that never happens never happens. Right, so currently on 4 times 250 milligrams per day of urso, so on 1,000 milligrams per day, which they're taking 2 in the morning, 2 at night to split it up. But they're having a lot of tummy issues such as cramps, upset stomach, and really bad flatulence. Is this generally normal when starting this medication?
Yeah, it can be. It can be. At the end of the day, urso is a bile acid, right? And whenever you feel sickly and you vomit up green bile, and your stomach feels horrible, that's bile. That's what bile does. That's what bile does. And so it, some people are fine, and some people get a little bit of stomach disturbance, and some people have a real problem with it. Now, urso is a good treatment, but it is not a miracle treatment, and it's important to bear that in mind. And when urso was the only treatment we had, it was a really, really good treatment, wasn't it? I mean, you had no other options, but we do have options now. So what would I do? So if you're sickly with it, then the first thing I would do is play around with the dosing, play around with the timings, and play around with taking it with food. So ignore what the pharmacy say. You try taking it before food, after food, all in one go, first thing in the morning, last thing at night. And try halving the dose to start with, and then seeing if you can build it up. So all of those fiddles are fine. All of those won't affect its function, and basically are routes to be able to take it. So when that happens, a lot of people are actually fine taking it. So drop the dose down, change how you take it around food. Whatever you're doing now, do something different, see if that makes any difference with it. Is a perfectly reasonable thing to do. And then if that works pretty well, you can then build it up. If that doesn't make any difference, and we certainly come across people where they do all of that, it makes no difference, then in this day and age, I would just go and take elafibranor, okay? Certainly if you're in the UK. So obeticholic acid, where it's available, elafibranor, seladelpar are all licensed as second-line treatments in PBC and as first-line treatment in people who are intolerant of urso, okay? And what you're describing is urso intolerance. And of those, probably the easiest one. So in the UK, we don't have seladelpar at the moment. Obeticholic acid can cause itch in some people. So the easiest one to give to people is elafibranor. Okay, and so I would have no hesitation with that. It's a really good drug. I've never had somebody who can't take urso who was unable to take elafibranor. Better than obeticholic acid in that. Remember, obeticholic acid is also a bile acid, elafibranor is not. So obeticholic acid, you give it a much lower dose than you would do, urso. So you give quite a high dose of bile acid. But it is still a bile acid, so therefore it theoretically can do it. So elafibranor has basically made this go away. And I think sometimes people say, oh, it's really expensive and all of those things. But no, actually, it's a really good treatment and it really controls the disease. And, as we've said before, we think there's an itch benefit. We think there may be a fatigue benefit. And most of all, people just take it and they're fine. And I think part of the mythology about PBC, it's all made to be more complicated than it really is. and too many mythologies about it, and about, oh, we can't do this, can't do that, and the other. And truthfully, if everybody was diagnosed with PBC, was given urso and elafibranor or something, then most of what we see as problems would disappear, actually. And so we, and by that I mean we, the doctors, have made this overly complicated. I always say to people, I spent the first half of my career making everything more complicated, and the second half of my career making it simpler again. And I think that's true. Sometimes people want to be, this knowledgeable sort of, like Yoda, uttering these meaningful sayings, and actually we just make it overcomplicated. We just make it overcomplicated.
I think that's the benefit of the position we're in now, isn't it? When we've got multiple second line treatments, is because everyone's different. We've got different options now.
Yeah, and I think I think that's right. And I think it's going to be one of the big questions. So, if all you've got is urso, that to a hammer everything looks like a nail. If all you got is urso, that's what you're going to get. And then if you've got urso followed by obeticholic acid, then it's urso and obeticholic acid if you need it. And now we're into a position of which treatment do you use? And of course, there'll be two reasons why you would use one treatment rather than another, or three really. One would be if you knew in that person it was going to work better because of the nature of the disease. And that's the really grey area. We don't know about why people have worse disease. Some people have worse disease. Some people have better disease. So there is a knowledge gap. And you'll go to the ASLD meeting, very nice, awesome, lovely at this time of year. So you'll go to that, and nowhere you'll hear lots. I mean, I think there are 170 PBC abstracts or something like that. Okay, but nowhere is anybody answering the really important questions. Okay, so what you'll see, this is the nature of research, is that lots of people will answer the same question repeatedly, just in a slightly different form. So 2 years of this treatment, 3 years of this treatment, and these will give rise to information which is valuable but not surprising. Okay, mm-hmm. So they are important, but they don't change what you know. And actually, that's just in the nature of science. That's what people do. This is passive least resistance. And actually, the really big questions is, which of these drugs should I give? And the reason why that matters, because people get choice paralysis. Okay, I wouldn't be so unseemly as to make a comment about women going shopping for clothes, but sometimes if you have so many clothes to choose from, that can mean you don't actually buy any. Okay, and men, because basically, I mean, why have a second pair of shoes? I'm a man. Why do I have a second pair of shoes? I mean, so you can have too much choice. That was terrible, wasn't it? You can have too much choice, can't you? And I think a lot of clinicians are scared of using the wrong one and therefore don't use one, whereas, of course, not using one is the wrong thing to do. Mm-hmm. And the right thing to do is to use which one, kind of, as far as we know, feels like the best for an individual, and then just watch what happens. And if it turns out the way you wanted it to, great. If it turns out not the way you wanted it, in terms of control and things like that, you try one of the other ones. Over time, clinicians will gain a feel for it. So most doctors do not use vast numbers of different drugs. Probably in my practice, I would have 20 drugs that I would prescribe, no more than that. But they are ones I prescribe all the time. And why is it those? Because they're the ones that the evidence is there for, but which I have a feel for. I am familiar with them. I know what they're like. I know what they do. No surprises. And so that's what we tend to do. And I think so which is the right drug for an individual, we'll learn with time. Side effects will be important. So obviously the itch with ochre is an issue and we're aware of. Probably all of them. You've got to be careful with very advanced cirrhosis. But the third one is that familiarity, which is that out of a choice between a drug I've never used before and one I've used all the time, I will always use the one I've used all the time, because I have a feel for what it's going to do and what I should be looking out for. And so the problem with trials, of course, is that they deliberately bypass all of that. So clinical judgment about different treatments. But I can't emphasize enough, if you're sitting out there with an alkaline phosphatase over about 200 or a bilirubin that's elevated, and you're not on second line treatment, you need to be, or at least very seriously consider. And any of the treatments is far better than being on none of the treatments. And we have really good options that are really effective, and almost certainly they slow the progression of the disease, they reduce the risk of it all, they will reduce the risk of symptoms. So I think that's the message. That's the message. So on that moment, can I just say, coming shortly, the next 2026 edition of the book, okay? So, which I'm busy proofreading. Why have we done another version of it? Because to answer all these questions is to specifically talk about ochre. Why is it not there? Why might it be there? What's all of this? Should I have elafibranor or seladelpar? I'm hearing these things said by different people. What on earth do I do? So I've updated it basically to take account of all of that, because I think that's the really important question now. And the worry is, as I said, not getting the wrong one, it's getting none, and therefore losing out because of it. And I think that is a problem. So that was a shameless plug. So it was available fairly shortly when I finished proofreading it. It's amazing how much changes. I mean,
it's been such a time of change, though, hasn't it, in terms of what's happening?
You look at some other diseases and things like that, and so little change. As I said in the American Liver Meeting, it's consolidation. I think the big three things are we are anticipating linerixibat to be approved fairly shortly. So that's the new GSK itch drug. And that's really important. So we're learning how to use that drug, who's the right person for it. Personally, I think it's going to be for people with more severe itch as an option. I think it's the big bazooka, if you like. Maybe short courses to break a cycle. Yeah. So we'll be doing so. It clearly works. But, how do we use all of that? And then the other is learning about the longer term use of elafibranor or seladelpar, their safety. How do we use them? What else do they do over and above, their pure liver function test improvement? If you pin me down, I would say they're quite similar. I think seladelpar is better for itch, and I think elafibranor is better for fatigue. Not sure I quite understand why that is, but it seems to be quite a consistent picture. And I think it would be nice to have another licensed option for itch. Just to pick up a thread from the last time I did one of these was that around the rifampicin situation.
Yeah. Mm-hmm.
So to recap, problems of getting hold of rifampicin. Mm-hmm. So the messaging for people is to talk to your hospital consultant, who needs to talk to their pharmacists. Okay. So we, in our organisation, spoke to our senior pharmacist, who spoke to NHS England, and he got an exemption to allow us to prescribe it. Okay. Mm-hmm. And our agreement is that we will avoid starting it if we can, because there are other options, although we can still start it if those other options haven't worked. But we wish to be able to continue it in people who are benefiting from it. So we are now back, we can issue prescriptions again. It's a bit more of a clunky system than it used to be, but we can get rifampicin. You will not get it from a community pharmacy. It will have to come from the hospital pharmacy. So if your consultant says they can't, they need to talk to the pharmacists. And if they have trouble with that, we can give the contact details for our chief pharmacist, who can guide them through it. So that's much better. It's all we asked for was some common sense about it, because rifampicin can be a drug that people really need, where they've really struggled to get it under control in other ways. So again, that's another slightly positive thing. And they are rushing through the linerixibat approval as we speak, in order to give us an alternative option for that. GSK can provide it on a named patient benefit basis. So what that means is you can get it before it's licensed, based on what we know already. So if you're really, really struggling with itch, okay, again, this is one to talk to your consultant about. If they are a kind of PBC geek like me, or the Birmingham people, or the Royal Free or King's or something like that, they can deal with all of this. If they're not, probably you're going to need to come under one of those centres, because you're into kind of the small print stuff. And Linarixabat is very safe. It's just, we're not supposed to use drugs that aren't licensed. But that GSK, as all the companies have been, I have to say, understanding of the situation and very keen to do whatever they can to help. So there is progress, but I think rifampicin will become a little bit more available, so that's good.
That's great news about the Linarixabat as well, because that means that there's another option for its treatment, because we know what the impact on quality of life that can have. If anyone is needing some assistance on how to get that compassionate access, the named access, get in touch. We can help support on that as well.
And I think the companies are, it creates a lot of paperwork to fill in, but the companies are very good about this. And at the end of the day, it's also useful for them, to be honest. I always say to all of these companies, they say our drug really works for itch or fatigue. Do you agree with us? And the answer I always say is, give it to me for 6 months in my clinic and I'll come back and tell you. And I'll tell you because people will come back and say, God, my itch has gone. People often say, what's a significant change in an itch score that really matters to people? And I say, realistically, I will know a drug works when somebody comes along and says, I haven't got an itch anymore. Other than that, it's all shades of grey. And we should be ambitious about that. I think, GSK would string me alive for saying this. I think Linarixabat's most use will be to have a stock of it and to take it for a pulse if you're having real problems. Okay. So I think it's going to be an episodic treatment. So if you're having a bad itch time, you take it for a couple of weeks and then you stop it, probably because of the GI side effects you can get with it. So rifampicin, you absolutely must take it all the time, otherwise it stops working. But Linarixabat will be quite like paracetamol for itch. Actually, you can take it when you need it and then not take it. GSK would point out that it's only licensed for continuous use, etc., etc., etc. And we will say, yes, of course it is, and then do exactly what we want to do, which is what we always do.
And again, it's just important we've got options, isn't it? Different options for different people when it's needed. So
you need different options. The part of the problem is a lot of the people who make these decisions or write, guidance and things like that don't actually see patients. And the real world is more complicated than it appears in theory. And people do respond to different treatments different ways. They tolerate different treatments in different ways. And the real problem for us is if you have a single treatment for something and somebody can't tolerate it. So whatever anybody says, more options is good, because that increases the likelihood that we can find an option you can tolerate. And then as we get to learn more about it, we can fine tune which treatment we give to which individual. Again, for what it's worth, I don't think we're going to have some magic miracle treatment that's going to come along that is curative for PBC. However, I think that once we learn how to use the drugs that we have now to their best advantage, it will have that effect. So I often say, I think with the exception of a specific fatigue treatment, I think we have all the drugs we need. We just need to learn how to use them. And with my usual intellectual depth, I always then talk about the Eric Morecambe, Andre Previn sketch where he goes up to the piano and just hammers the keyboard. And Andre Previn, after this big build-up, and Andre Previn says, what on earth are you doing? That's a terrible noise. You're playing it all wrong. And Eric Morecambe goes, I'm playing all the right notes, just not in the right order. And I think we're playing all the right notes, just not in the right order. And I do think my personal bugbear is delay. I think delay is the enemy of all of this. I think we take too long to make decisions, too long to diagnose it, too long to start treatment, too long to assess how that treatment's working, too long to start another treatment. Because I think we're losing opportunity to treat it effectively all the way through. So there you go. On that, I bet none of the other people who do this talk about Eric Morecambe, do they? All the right notes, just not in the right order.
Right, thank you so much.
Questions, or have I just waffled on?
You have answered all the questions that we have today. I've got a clear slate. It is never happened. So I will take that as a first. And we can start getting our questions in for our next one.
Well, frankly, people are bored of me and bored of me wittering on. And I mean, on a serious note, so come back next time we speak in one of these, take the temperature of ASLD, because for years and years, PBC was the Cinderella condition, that it was something people didn't really think mattered. And then just last year at the European Liver meeting, it flipped. And all of a sudden, that's what people were talking about. And all of these years of arguing about the need to treat this better and take it seriously and not ignore symptoms and not all of those things, and finally for people to really take it seriously is just, it's very heartening, and the progress is immense. And so I'd just be interested in whether that's the case. And it does. About 12, 13 years ago, jokingly, somebody asked me, when we were setting up UK PBC and the platform that we do and all of that, somebody asked me, you know, how are you going to approach this? And basically, and I said sort of jokingly, we're going to take this disease and shake it till the answer comes out. And the whole point was to basically look at every single aspect of it from beginning to end until we had all of the answers, rather than this never-ending sort of slowly research thing. We're going to start with the problems and work backwards, rather than starting with the research and try and use it. And, you know, 15 years later, here we are, you know, with all these therapies and all this awareness. And who's to say shaking a disease till the answer comes out isn't the answer? What I would say is that the world of PSC, when we started UK PBC, was more advanced than the world of PBC, okay? And they still have no treatments. And maybe shaking, you know, picking up a disease and shaking it till the answer comes out. But on a serious note, what's the problem here, okay? It's not difficult, is it? I mean, you know, most scientists go, oh, I'm going to look at this molecule and this gene and this, that, and the, and oh, and I'm going to look at that, and then I'm going to look at that. And the other way of looking at it, very much the UK way, the NHR, the UK funding body, is right. What are the problems here, right? And then what are the problems? What really matters to people? Why does it matter? And then you work back into that. And that's where all the things we do now have come from. So first of all, let's not have people die of PBC. Let's not have people develop cirrhosis, because that's miserable. So we've done all of those things around that. So let's make sure that everybody gets that treatment. Still some work to do on that. And now we've done all of those things. Symptoms are a problem. So let's get to grips with that. And you think that's obvious, but to scientists it isn't, because why do that when you can look at this molecule?
And that's the reassuring thing for patients, though, isn't it? For day to day, it's symptom management. So seeing treatment starting to come for that is
oh, the next big thing will be fatigue treatments, no question at all. Either existing treatments used in the best way to control fatigue, or, and I think it's each way both, or both, actually, to be honest. I mean, I think, you know, the thing we did at the PBC, you know, the patients, you know, conference, where we asked people who here only develop their fatigue after they're on second-line therapy, and nobody, okay? So I have a theory that if you're on second-line therapy, you don't develop fatigue if you've not had it before. And what does that tell us? It tells us that you need to get those treatments in better and earlier. So I think that's where the Eric Morecambe thing comes in. Of course, you know, if the Eumacrine work, if you have a specific treatment for fatigue, that's a game changer, okay? And by the way, if this drug works for PBC fatigue, I will bet you anything it works for chronic fatigue syndrome as well. I bet you anything, okay? Because I think it's the same process, but for different reasons. But we'll have to wait and see. I've posed my all my own questions and answered them. I have to tell you, once they had a debate. I don't know if I'm a scary person. I don't think I am. But they had a debate at the British Liver meeting once, which was about this house believed that obeticholic acid was the right treatment for PBC, and versus this house thinks that bezafibrate was the right treatment for PBC. And they couldn't get anybody to debate against me. Okay, so I said, look, I personally, I think obeticholic acid is a much better treatment, but and I said, look, I will argue for bezafibrate. I'm not, you know, I used to debate, you know, I'm happy to debate either side of it. They couldn't get anybody to do the debate, so I did a debate against myself. So we had two lecterns, and so I would say something, and then I'd go to the other lectern and I would answer it. It was a lot of fun, actually. So I am used to answering my own questions.
Good.
I did tell myself I didn't know what I was talking about. I need to read the literature about. I got quite carried away in telling myself off.
Right. On that note, we will see you again soon.
All right. See ya.
Take care. Bye.